Morning, everybody. We're getting a little bit of a late start, and I apologize because I'm giving a talk 5 minutes after the end of this one. I'm going to have to run to the other end. So I may go over a few minutes, but I can't go over too long. So this is a talk on RNS as a treatment option for drug-resistant epilepsy. And perhaps some other folks will join us, but I'm gonna review what RNS is, how typically we get to the implantation of RNS, and then I was here at the tail end of the last talk. There were some interesting questions about RNS versus VNS, or how, what neurostimulation device is most appropriate, and I'm happy to try to address any of those. So let me just quickly go through some of the introductory slides, and then hopefully we can get into what is RNS and how does it work. So first, let's begin with sort of the general topic of drug-resistant epilepsy. So this is the problem that brought many of us either into the field or to the conference today. So drug-resistant epilepsy is typically identified following the failure of two appropriately selected anti-seizure medications to control seizures. So these are typically patients that have oftentimes tried not only 2, but 3, 4, 5, 6, or 10 anti-seizure medications and still continue to suffer seizures that are disabling and affect their quality of life. So this slide really exists to just identify the two different nature types of seizures, focal seizures versus generalized seizures. So generalized seizures are apparent bilaterally at onset. If we have EEG electrodes hooked up, we typically see the onset of the seizure occur in both hemispheres, and we typically see you can either see bilateral motor phenomenon, as in a tonic-clonic seizure, or absence seizures, sort of without any obvious motor phenomenon occurring with generalized seizures. Focal seizures, on the other hand, are typically manifest or have seizures that have symptoms that relate to where the seizure begins in the brain. And it's really the focal seizures that were the initial target of RNS therapy when it was in development stage, and is still primarily the type of seizure and type of epilepsy that RNS is used for today. So there are lots of treatment options for drug-resistant epilepsy. Lots of new medications come out all the time. As we know, the first drug typically obtains adequate seizure control in about half of patients, and then the second drug about 13%, and it becomes sort of a law of diminishing returns, such that once you've tried 2 or 3 seizures, your chance of being seizure-free is less than 5% on medications alone. And that's when patients really should be referred to a comprehensive epilepsy center for a surgical evaluation. Surgical evaluation doesn't necessarily mean old-style surgery. It can mean a variety of things, including RNS, but that's really the beginning point at which patients and their families need to think about RNS or another type of implanted neurostimulation device. So RNS has gone through the FDA approval process. It is not experimental. It was experimental 15 years ago. It's not experimental anymore. It's been FDA approved, and these are generally the guidelines for use of the RNS system today. So it's approved for patients 18 years or older. Patients need to meet the definition of drug-resistant epilepsy, so they must have tried at least 2 anti-seizure medications and still suffering from seizures. Seizures must be focal or have some focality to them. This gets a little bit more complicated, and there's some ongoing studies to look at other kinds of epilepsy syndromes. And then the seizures actually have to be frequent enough, and their physical manifestations have to impact quality of life. So these are generally the criteria that are required to fulfill in order to explore really the possibility of the RNS system. So Identifying patients for RNS oftentimes requires admission to an epilepsy monitoring unit for at least what we call a phase 1 study. So a phase 1 study is where patients are brought into a dedicated unit. Oftentimes their anti-seizure medications are reduced in order to capture seizures and identify where they're coming from and what the physical manifestations of those seizures look like. Once we've identified focal seizures or a focal epilepsy syndrome, then we can go on and talk about what the most appropriate options for the best control of those seizures are. The RNS system is oftentimes most useful in patients that have 2 different areas that seizures are coming from, and it's not feasible or recommended to remove both of those areas. So probably the most common situation that occurs is when patients have bilateral temporal lobe epilepsy. Temporal lobe epilepsy is the most common form of drug-resistant epilepsy in adults. So if you have seizures coming from both the left and the right temporal lobe, a surgical resection of one or the other is not going to result in seizure freedom, and thus we then look for other alternatives. And one of the good alternatives then is the RNS system, because you can actually implant both right and left temporal lobes and treat both seizures coming from both areas. Another scenario would be when seizures are coming from what we call eloquent cortex. So that's a part of the brain that is involved in very high level sensory, motor, language, speech, vision functions, such that, well, yes, we could probably take out that area of the brain, that abnormality that's causing the seizures, but it would introduce a permanent and irreversible deficit or neurological problem that we obviously don't want to give that to a patient. So those are the kinds of situations in which, on a routine clinical basis, the RNS comes up and becomes the topic of recommendation or discussion along with epilepsy surgery. So this slide really just highlights the different types of surgical procedures that are available. The first column really is resective surgery. This is old-style surgery that oftentimes requires a craniotomy and a longer hospitalization. It oftentimes involves removal of a larger area of tissue. Lobectomy, a temporal lobectomy or a frontal lobectomy falls under the category of resective surgery. Then we have laser ablation, which is a newer form of destroying the tissue that generates the seizures. And then finally, neuromodulation devices. VNS or DBS, that's a non-specific neuromodulation device, and then RNS system. And as you can see on the slide, the RNS system not only does it target the source of seizures in the brain, but it preserves brain tissue. There's no destruction or removal of brain tissue. It's adjustable or programmable by your neurologist or epileptologist, oftentimes with the help of clinical field specialists and scientists from Neuropace, the company that makes the device. And it selectively recognizes in response to brain activity. So I have, courtesy of some of our Neuropace friends, I have, if nobody's seen one of these before, this is what the generator looked like without the key ring. We don't implant the key ring in the head. So that's what the RNS battery and generator look like. That's actually implanted in the skull, so there's a small amount of bone that is removed, and then a thin titanium tray is implanted, and that RNS generator rests in the tray. The wires come out of the RNS generator and then are located either on the surface of the cortex that's generating the seizures, or deep in the brain, implanted with depth electrodes into the area of the brain that the seizures are arising from, if that happens to be a deeper structure. After it's implanted, basically it's not visible to the eye. You can oftentimes feel the device if you're palpating the skull, but the skin heals up over the generator, and people walk into my clinic with RNS devices once a month when we have our RNS clinic, and you wouldn't be able to tell them from any other patient in the clinic. One of the nice things about implanting the RNS system is it's a relatively short hospitalization. It's usually 1 or 2 days in the hospital max, and then patients go home with the system. We oftentimes will let the RNS system acquire data for the first 2 weeks or month before we turn on the therapy, that is the stimulation that recognizes and tries to abort the seizures. So probably skip over this slide other than to indicate that the newest RNS system has a very long battery life, longer than we had certainly anticipated based on the first system. The estimates are about 11 years is the battery life of the current RNS system. Of course, that depends on how you set the therapies and how many therapies you're using per day, but it does have quite a long half-life. I'm going to just talk for a few minutes about how the RNS system works. So as I mentioned, when we implant the system, we've already identified the areas of the brain that are generating the seizures, and then we implant electrodes either on or in those structures, and those wires are then connected up to the little device, the computer that is circulating the room. That computer then stores data. It recognizes the onset of a seizure. That onset doesn't always become a seizure. Sometimes it's just the very beginning of the seizure, and it would die down. But the RNS recognizes all of those and stores them. It will selectively store seizures. It will selectively store episodes that are identified by the use of a magnet. The patient has a magnet and can identify seizures that the RNS should store. And then basically what happens is when the algorithm, the mathematical algorithm that we have selected to identify the seizure goes off, that will trigger treatment. And treatment is a small electrical burst of electrical activity that is designed to suppress the seizure. Oftentimes, a seizure onset will trigger a whole series of 5 treatments with a short course of electricity to try to abort or terminate the seizure before it stops doing so. And then ideally, as you can see on the slide, after the RNS device identifies the seizure or ictal onset, and then provides the treatment, basically the electrical stimulation, hopefully the brainwave activity then reverts back to normal, rather than evolving into a seizure that would otherwise disable the patient. So this is how the system works. And many of our patients are surprised that the RNS system is identifying over 1,000 or 2,000 seizure-like events per day. These are often called long episodes. They're not having 1,000 seizures per day, but oftentimes 1,000 times per day or more, there will be a brief electrical discharge that looks like the beginning of a seizure, and the RNS is trying to stop anything that might go on to become a seizure from doing so. And so oftentimes our device will go off 1,000 or more times a day. The RNS system has to be personalized, it has to be programmed and really adapted to a patient's individual seizure signature. So some of them have, some seizures begin with these very high amplitude spike and waves that you might have seen on your EEGs. Some of them begin with low voltage fast activity, and we oftentimes Thank you. Yeah, you can just go ahead and leave it there. And so there's oftentimes a learning curve where we're collecting data on what patient seizures look like, and then we're updating the RNS device then to identify those and selectively deliver an electrical current for those events to stop those seizures. So this device that was circulating on the keychain, the generator, and the chips that govern the operation of the device, they can hold up to 8 episodes of EEG, 8 seizures, or bits of 90 seconds of brainwave data. So every day or every couple of days, patients will have to download that data from the chip. The system comes with a wand that patients will hold over their head, and the data will get transmitted from the RNS generator in the scalp through the wand to a laptop, and then about once a week, patients will typically upload that data to the server, and that allows us, the neurologist, to then review their seizure activity. How are they trending? Are we capturing the right thing? Patients may be using a magnet to identify, hey, this was a seizure that I experienced, but we don't actually see the device capturing that. And so we need to program the device to be selective to the events that the patients are identifying as their important seizures to recognize and to treat. And on the other hand, sometimes, more often, is the case that patients aren't even aware that they're having, 20 or 30 seizures a day. Now, they're not always disabling seizures, otherwise they probably would. But we basically, there's a learning curve is the point that I'm trying to make. And for the first 3 months or so, we're just trying to drill down to what an individual patient's seizures look like, and to tailor the recognition and the treatment, that is the delivery of an electrical stimulation, to that particular patient's seizure type. I mentioned the magnet. The magnet is, every patient is given a magnet, and this does become a little bit of a source of confusion between patients that have had VNS or have a VNS, and then go on to have an RNS system, because the magnet functions a little bit differently in the two systems. So for RNS, the use of the magnet over the generator captures 90 seconds of data that is important for the neurologist to see. It's time stamping and saving a bit of data so that the neurologist can go back and look at that and analyze whether or not the RNS device picked it up, did it treat it effectively. And then, as I mentioned, that gets uploaded to the cloud, and we're able to view it from the office, as you can see in that lower right-hand corner. That's the screen that we typically see with the seizure activity, this 90 seconds of seizure activity. I am going to stop the formal presentation on this slide. This slide basically just shows you the results of published real-world data with the RNS device. So at year 3, on average, there's about an 82% seizure reduction. Now this is all types of patients, temporal lobe, frontal lobe, bilateral, multiple sites. So I'm gonna, as I mentioned, I'm gonna end here. We got a little bit of a late start, but I don't know if is somebody giving another talk in this room right after me? All right, so I've been shortchanged today, but that's okay. I'll take just a couple of minutes to answer questions that folks might have. Yes?
Does the VNS implant stay, or do they remove that if they should move on to the RNS?
I have a handful of patients that have both. I have not had a patient in which we have removed the VNS. I know there are patients that oftentimes will have may have the VNS turned off if the RNS turns out to provide better seizure control. But most patients remain with the VNS They really, in some instances, they are complementary of one another.
Oh.
They're both neuromodulation devices, but they work in different ways. And there are some advantages of RNS over VNS. There are some advantages of VNS over RNS, and sometimes together. I have one patient who never really responded to VNS, really did respond to RNS, but when he has breakthrough seizures, wants to have the magnet to try to stop them. That's a very, very common scenario.
Okay.
Yes, please.
Does RNS differ from Neuropace?
I'm sorry? How is
How does it
RNS?
differ from Neuropace, RNS?
RNS is the trademarked term for the device that's made by Neuropace.
Oh, okay.
Yes?
Is it typical to require a tissue expansion prior to, seating the RNS device?
No. I've never heard of that. It goes within the skull, so it's just there's a bit of the skull that is removed in order to fit the plate in. I'm gonna hold it there because I need to be at the other end of the conference center now. So, thank you all.